Good evening, all. Good evening, good evening.
Good evening, everyone.
Good evening.
Can you hear me? No? Oh,
Yes, yes, we can hear you.
yeah, it's telling me my network is a bit unstable, so hopefully I'll be able to get through the evening. Hope everyone's doing well. We're going to get started in a few minutes. Just trying to organize myself here. Not the best. Maybe I need to relocate it. Okay, it seems better.
They tell you if 5G be better for the
Good evening, all.
Okay, good evening, everyone, and welcome to our monthly meeting. We have had a very long summer break. Y'all got an extra 2 weeks even.
Good evening,
So thank
good
you all for
evening.
joining us. So happy that you remembered the date. Good evening, everyone. And we're going to get started with a prayer.
Good evening.
Can you hear me? If you all can pray with me. No. Heavenly Father, we ask for your guidance and wisdom as we gather today. May our hearts be open to listen and our minds be clear to communicate. Fill us with your grace, Lord God, and continue to remind us that all that we do for the Cancer Society and all that we accomplish in the service of humanity. In your name we pray, amen. So like I said, welcome back, everyone. Hope you all had a good summer, some vacations, some trips, shopping, and I hope the kids are all back in school and well settled. Do we have anyone celebrating birthdays, anniversaries, or milestones that they want to share with us this evening? If you do, please open your mic and let us know who you are and what you're celebrating. Or if you celebrated over the summer holiday while we were on break, you can let us know that as well. Nobody? Wow. If you don't have audio and you want to put it in the chat, let us know. If we don't catch it now, we'll catch it before the close of the meeting. While we wait on that, Erin, do we have any announcements for tonight?
Yes, we have an announcement. I don't know how to say this, but welcome back, everyone. Next month is Breast Cancer Awareness Month, and usually the Cancer Society has breast cancer shirts, but unfortunately this year we don't have any new design because we are coming out in January with a bigger, better, prettier,
Older.
all that, yeah, all that good stuff. So if I could just, can you see my screen? All right.
We can.
So these are our shirts that we had designed from last year. We still have quite a bit in stock. So we have discounted these tremendously because we want to make room for our new design for the 50th anniversary. So come down and get your shirts early because they're limited stock and limited sizes. And like I said, we do apologize on behalf of the Cancer Society of the Bahamas. We extend apologies for not offering the traditional breast cancer awareness shirts for October. And, we appreciate corporate sponsors and individuals that come and look forward to our shirts. But while we have not produced any shirts this October, we are excited for the milestone of 50 years. The Cancer Society has been in existence starting from 1976, and 2026 will make 50 years. So it's we want to come out with a bang. We want persons to remember the 50th anniversary. So we're coming out with a collection that will be wonderful. Well, not just shirts, we're gonna have tunics, you just stay tuned to the media and you will start seeing some of our designs soon. So we're thankful and grateful for the opportunity and the partnership, and we look forward for y'all supporting us for the 50th anniversary. And it's coming in October, but just putting it out there, those who like bingo, mark your calendar, October 25th. It's bingo at Super Club Breezes. And that's it for the announcement.
Okay. Would like to introduce you all to somebody new to the Cancer Society. We have with us today Patrice Moxie. Patrice, I don't know if you can turn your camera on. Patrice is our new assistant administrator who joined us earlier this month. Do you have your camera on, Patrice?
Yes.
Hello.
Hi, Patrice, and welcome. So this is a face you'll be seeing more of. Thank you, Patrice,
Good night,
for joining.
everyone.
Good night.
Good night. Okay. So with all of those formalities now out of the way, I am going to introduce our speaker, who may not be a stranger to many, Dr. Theodore Turnquest. After graduating high school from St. John's College in Nassau, Theodore Turnquest left the Bahamas to begin his studies at the University of South Florida in Tampa. He completed his studies, earning a Bachelor's of Arts degree in chemistry, which allowed him to pursue further education at the university's College of Medicine. After receiving his Doctor of Medicine degree, Dr. Turnquest set off to Baylor College of Medicine in Houston, Texas, for his residency in internal medicine. He then returned to the University of South Florida to complete his hematology and oncology fellowship at the H. Lee Moffitt Cancer Center. After completion of his postgraduate training, Dr. Turnquest passed his board exams and retains board certification in internal medicine and medical oncology, as well as board eligibility for hematology. In 2002, Dr. Theodore Turnquest moved back to the Bahamas in Nassau, where he is a consultant in medical oncology and hematology for the Public Hospital Authority. He provides clinical hematology and oncology care for the public hospital system, including directing both inpatient and outpatient activities. In 2002, Dr. Turnquest established his private medical practice, Oncology Consultants Limited. Here he provides medical oncology and hematology services for local residents and tourists alike. Dr. Turnquest assists in nursing education, community awareness programs, and civic group programs on cancer screening and advancement. He is actively involved in oncology research in the Bahamas. He has completed studies on the genetic component of breast cancer in Bahamian women. He is also currently developing a PCR lab where genetic and molecular defects can be detected locally. So that's a really great resume, Dr. Turnquest. So now I'll turn it over to you.
Well, thank you for that. I'm going to share my screen now. Let's see. Okay. Can everybody see that? Yeah.
Yes. Leukemia Cancer Society Bahamas.
Yes. Okay, great.
Yes.
All right. Well, thank you very much for the opportunity to give this talk this evening. When I was asked to give a talk on leukemia, I said, "Oh, how am I going to do this?" Because leukemia is for a hematologist is a pretty broad subject with lots of pieces into it. But I figured I'd sort of digest it down into sort of bite-sized forms and just hit mostly the highlights with broad strokes. So the goal of this talk is really to, one, get an operational definition of leukemia. We're going to talk about different types of leukemia. We're also going to talk about what populations get leukemia. And we're going to talk about signs and symptoms of leukemia that people should look out for and what they mean. I'm also going to break into the major types of leukemias and some of their classifications so that you have an idea when somebody says leukemia, what they mean and what the outcomes look like. We're going to touch a little bit on some of the causes of leukemia. I think that's a question I get pretty often, what caused this? And lastly, we're going to touch briefly on how we treat leukemias, because that's a pretty broad area as well that's evolving. All right, so the word leukemia. So for some of us who may have gone to GHS, well, not us, some people who went to GHS, they did Latin or leukos is the Latin word for white. And emia, you see emia at the end of the word, it usually means blood. And so on the right hand of the screen, you would see somebody holding two vials with blood in it. And this is what blood looks like if you put it in a centrifuge and spit it down. The vial to the left is a normal blood once it's been spun down. And you can see basically two, maybe three sections on that, right around the 3 mark. On the one on the left, you see this sort of white line, and that's called a buffy coat. Below it is going to be what we call red cells or packed red cells, and above it is plasma, and that's what it normally looks like when we spin it down. On the test tube on the right, you can kind of see where the thought about comes in about leukemia. You see that buffy coat is vastly expanded, and it is literally white, or it looks white. The plasma volumes is decreased, and the amount of red cells that we have is also decreased as well. But really, we kind of don't see that much anymore. So in real life, it actually looks more like this. We go to the microscope and we look underneath the microscope, and what we see on the left is normal blood, which has a lot of red blood cells, small dots, which are platelets, and very few white cells, as opposed to smear that we look at under the microscope, where you see all these big pink round cells and the like. And that is an example of a leukemia. And that's where the word, part of where the words come from. You get an expanded amount of white cells in the bloodstream. So where do we actually produce these cells? Well, we produce all of our cells in our bone marrow. And the bone marrow is that brown, spongy stuff between the bones. When you bite off the head of a chicken bone, that's that marrow stuff that we love to suck on. And that's in that space, that's where our stem cells, our blood stem cells, live. And they go on to produce all the cells that we have in our blood. So they produce red blood cells, white blood cells, and all the different combination of white blood cells, and also platelets, which is how we stop marrow that we use to produce our blood cells actually decreases. And so that's going to become a little bit more important later on. So this whole thing about stem cells, and it's been all the rage for the last 10 years now, I think, in the Bahamas. But what we're talking about is the stem cell that creates, it's basically the mother of all the cells in the marrow. Now, stem cells can mature along different lines. And in this cartoon, what I'm showing is stem cells can go along what's called a lymphoid line, and they eventually, inside the marrow, mature and become lymphocytes in the peripheral blood. They can also go along what's called the myeloid line, and they mature and go along and become what we know as white cells in our peripheral blood. They can also turn into red blood cells, and then they can always also turn into cells called megakaryocytes, which later become platelets. So what you see below the line is what we see in the peripheral blood. So as a consequence, when people have leukemias, either they have an overproduction of one of these cell lines in the bone marrow, and it's reflected in the peripheral blood, or they can have an overproduction of one of the immature cell lines, and the reverse can happen. It can actually stop the production of the other cell types, so it shows up as insufficient amount of red blood cells. So it's still a leukemia, but the leukemia hasn't gone into what we call the blood phase, essentially. So now we're going to talk a little bit more about white blood cells, because that's most of the leukemias that people recognize. But I want everybody to recognize that any one of those cell lines can become malignant. When I say malignant, but become cancerous. So white blood cells can go into leukemias. In this cartoon, we're also showing lymphomas, some myelodysplastic syndromes, but we're not going to get into those portions of the talk tonight. But in the leukemias, there's basically 4 forms that we can see. So we see that leukemias can be acute or chronic, which basically means fast growing versus slow growing. They can be of the lymphoid line, which basically that was the lymphoid portion that I pointed out earlier, or they can be of the myeloid line. And those are the basic 4 types of leukemias, broad categories of leukemias that you would come across in hematology. So what about the demographics? Like, who gets leukemia and when? So basically, when you're talking about acute myelogenous leukemia, the AML, they occur both in children and adults, and usually at I would say more the extremes of age. So very young children, so children from the age of sort of infants up till 5 or 6 years old. Then it starts to taper off, or adults as we get older, as changes in our DNA kind of catches up with us. And the ALL, or acute lymphocytic leukemias, those are a lot more common in kids than they are in adults. We do see it in adults, but way more common in children. And I'll get into how the outcomes are different. The chronic leukemias mainly affects mostly adults, and CML being sort of the prototypical chronic leukemia. And then there's chronic myelogenous leukemia, and then you have chronic lymphocytic leukemia. And we usually see this in people over the age of 55 into their 60s, with CLL representing one of the most common leukemias that you'll find anywhere. So what are the real signs of leukemias in children and adults? Well, one of the signs that's pretty evident is kids with recurrent infections. And they usually are infections that are, sort of nagging and just don't go away and keep coming. or they're symptomatic from a decrease in the blood cell line. Either their red blood cells are low, or their platelets are low, or their white count's low. So, and sort of looking at the child, you now looking at children who are sort of pale, have unexplained bruising, weight loss, night sweats, fatigue, fevers. So those are all signs that either the child is more anemic than he or she should be normal. The fever is signs of recurrent infections. The weight loss also is part of it as well. So the lumps portion of it has to do with if the leukemia has more of a tissue phase in the lymph nodes and the shortness of breath, more of the anemia, bone pain, and that's the part has more to do with leukemia ongoing more inside the bone marrow. So that from that first cartoon we looked at and expanding out than it is in the peripheral blood. So what does the same thing look like in adults? Well, in adults, it's similar, but not necessarily the same. It's usually a slower onset. Symptoms of fatigue and unexplained weight loss are a lot more common. And once again, the signs kind of depend a bit on which one of the cell lines are mostly affected. So if you have more red cells signs, people become more and more anemic, then they're going to get the shortness of breath, the weakness, the fatigue, and sometimes the loss of appetite. If it is that the platelets are going down, then they're going to get the bruising, the bleeding, and those sorts of symptoms. If it is that leukemia cells are now sort of getting trapped in organs, we can see that as people with enlarged spleens or enlarged livers. We could also see that as people with enlarged lymph nodes. One of the hallmarks of leukemia is that it's basically immune dysfunction. So you have these cells that are being produced in vast amounts, but they don't work very well. And so technically, almost all of these individuals, not almost, all these individuals are immunosuppressed. Therefore, the frequent infections, the fevers, all of those things, signs of infections, will be one of the manifestations of leukemia. So why do we care about the age? Well, in acute leukemias, age matters. And so this is a survival graph, basically for people who've been diagnosed with AML or acute myelogenous leukemia. And if you take a look, the age group 0 to 14, at 6 years, more than half of those individuals would be alive and well. Whereas if you take somebody over the age of 45, it's barely more than a quarter of those individuals would be alive with leukemia. And you can see as we get older and we get into our 30s, the chances of survival for leukemias historically, and I'm going to say historically, it's starting to change a little bit. Historically is not great. And that's why leukemia, I think, is one of those cancers that people are super afraid of because the outcomes don't look as great as the solid tumors. So let's talk first and foremost about the chronic leukemias, because they serve as a model for how the therapeutics have been starting to change over the years and our understanding. And the first one we're going to start with is the chronic myelogenous leukemia. All right, so once again, back to the microscope. So we look under the microscope and we see normal amounts of white blood cells, normal amounts of red blood cells, and normal amounts of platelets. But in people with leukemias, what we'll end up seeing in this instance is, increased amount of white blood cells on all the white blood cells, all the blood cell lines. And the other thing about this is that they don't function, like I said earlier, correctly. And as they proliferate in the peripheral blood, they're also proliferating inside the bone marrow. So you literally have crowding out of the normal cells being produced. This often results in platelet counts being lower, and our ability to clot goes down. On the bottom screen, this is what CML would look like under the microscope. So you see these big violet blue cells, but you see not just violet blue cells, you see cells that have sort of a little indentation in them. And then you see cells that are going all the way to be looking normalish looking white blood cells. So when we see this whole gamut of cells under the microscope, we're pretty confident that we know what type of leukemia this is. So this is usually a chronic myelogenous leukemia. Now, one of the interesting things about chronic myelogenous leukemia as well is that there's a specific mutation that occurs in the patient's DNA, which drives this whole series of events to happen. And that our current therapy is now actually based on taking advantage of that mutation. So CML actually became the poster child for targeted therapy and changing the natural history of a disease. And this literally only happened about 20 to 25 years ago. And so I don't know, well, for the doctors on this call who may remember this from medical school, and for any medical students that might be around. So I'm talking about this thing called a Philadelphia chromosome. And the chromosomes are basically what make up our DNA. But what happens with people with CML is, and turning over and dividing, something goes wrong with the switching. And therefore, one portion of the DNA is abnormally added to another portion of DNA, and you get a flip. And this is what makes chronic myelogenous leukemia. And what happens, you see down on the right-hand side, they talk about Abel kinase. And what it basically means, you get an abnormal protein that's produced that the cells get to a certain point, but they can't mature like they should. So they they get stuck, essentially. And so understanding this mutation was the first major breakthrough in the treatment of leukemia. So the medications that we put people on for this actually just take advantage of the mutation. So prior to this medication, the treatment for CML was chemotherapy and bone marrow transplants in people that were eligible. And up until the time that I was in fellowship 20-something years ago, this is how we did it. And right as I was leaving my fellowship is when these new drugs came out that we now use as targeted therapy in people with CML. And I'll show you a slide where we show the natural history of this disease has changed. CML, interestingly, also was the first leukemia where we did bone marrow transplants on for something called graft versus leukemic effect. And what that means is that we give an individual somebody else's bone marrow, reset it and give them somebody else's bone marrow, and the new bone marrow would recognize the old immune system as foreign, and it would attack it. And that was also a way you could treat somebody with CML. But that's kind of gone by the wayside now. because of the effectiveness of the targeted therapies. So this is a slide just looking at the outcomes for CML by years, and you can see pretty dramatically. So if you go back, into the 1980s, and basically, if you got CML at about 10 years, basically less than 10 to 20% chance you were alive. In the 90s, we got some newer drugs, interferon. It was a little better, but not great. When you got into the early 2000s, that the SCT stands for stem cell transplant, and interferon, it got incrementally better. But after 2000, and the imatinib became commercially available in 2002, you can see the 5-year survival in people with CML went to over 90%, and the 10-year survival went to over 83%. So contrast that from just basically 5 years before that, when the same numbers were 71 and 61%. And 10 years before that was basically 50-50 at 10 years. And so you can see that this has been a dramatic change. So much so that when we diagnose people with CML now, it's sort of almost a shoulder shrug for the hematologist, because we know that these people are going to do fairly well for a very long time. And beyond this medication, there's now 6 generations of medications beyond that. So we got a whole heap in the arsenal as far as this targeted therapy for individuals. So CML, chronic myelogenous leukemia, has truly become more of a chronic disease that's providing people are compliant with their medications. So we're going to switch gears now to the chronic lymphocytic leukemia. And this is the one that's, it is the most common type of leukemias that we'll find. It usually occurs in people who are a little bit older, 55 and older. And in our generation, the last 20 or 30 years, it's actually picked up mostly by just abnormal blood work. So people go in for routine blood work and their white count is markedly elevated. And then on the differential, they see, the white counts, they have more of these lymphocytes. And so when we look under the microscope, this is what we see. We see these cells that are pretty round and small, and there are just lots and lots of them. And they're a little bit more open than a normal lymphocyte as far as the nucleus goes. We also see, you see up in the right-hand corner, they call these smear cells or smudge cells. And that's because the cells are very fragile and they smear on the preparation of our peripheral blood smear. So this is another one where we can pretty much make the diagnosis just by looking under the microscope. There's other factors involved. So the other way we can do it is do something called flow cytometry. And what we're looking for is something called clonality, which basically means all of these cells are almost exactly the same. Not almost, they're exactly the same. We know in nature that should not happen in our immune system. Not everybody's exactly the same. Now, one of the key things about CLLs is that, and I'll show you why in a later slide, but it often doesn't really require treatment until much later on. So this is something where you diagnose somebody with leukemia and you go, okay, you have leukemia, you don't really have any symptoms, or you have minimal symptoms. There's no reason for us to do anything. We'll just keep an eye on it. And so I've actually followed people that I diagnosed with CLL going on 20 years now, and they've never required any treatment up to this point. Will they in the future? Possibly. Not really sure, because they've mostly been stable. So it's one of those leukemias that you don't have to do anything about right away unless something else is going on. So with CLL, it's a little bit different. You can find it in the bloodstream, or CLL can just be limited to the bone marrow, and those people show up as patients with all their blood counts are down, or what we call pancytopenia, or low white blood cell count, low red blood cell count, low platelets. Or the CLL can just be found in lymph nodes. And so that's the abnormal swellings that we were talking about earlier. So lymph nodes becoming enlarged, spleens becoming enlarged, and even liver becoming enlarged. So, like I said, for CLL therapy, just depends on stage. Earlier stage people, we don't necessarily have to treat. And even as far as the therapeutics goes, the world's changed. So we used to use a lot of chemotherapy, but it turns out for different populations, we don't have to do that anymore. People do quite well, actually even better with what we call small molecules. And that's the medications on here called ibrutinib. But there's a couple of different generations of that, and venetoclax as well. We also use immunotherapy. Rituximab, I think everybody who's even been remotely near the oncology world over the last 10 years has sort of heard about rituximab. So that's a monoclonal antibodies against B cells. And then we can always fall back on regular old chemotherapy. But increasingly, we don't have to do that. So here's a sort of graph or a median survival is well over 10 years, probably closer to 15 to 20 years. So which basically means it's going to be 10 to 12 years before you realistically have to do anything with them. Even with people with more later stages, it's still going to be a couple of years before you realistically have to do anything as far as therapy with them. And that's actually hold pretty steady over the 20 years that I've been doing this. And by all indications, it's probably going to hold for a while to come. So let's switch gears from the chronic leukemias now to the acute leukemias. So acute leukemias, by their very nature, are more aggressive and require interventions a lot sooner. So acute myelogenous leukemia, and this is the one from the myeloid line. So on the right, I put up the old FAB classifications. This is basically if you were to look at the leukemia under the microscope, and in not so much the peripheral blood, you can see this in the peripheral blood, but more in the bone marrow. Back then we had 7 subtypes of it. So the type of leukemia kind of depends on the cell of origin. The classification is based, like I said, what we see on the microscopes, but increasingly it's also based on what mutations that these people would have in their DNA or changes in their DNA. So the therapy can be targeted based on the mutation, and I'll go into that about one of the subtypes. Or we can use systemic chemotherapy, or we can use antibody therapy. But the goal for an acute leukemic is to remove basically all the malignant clones or all the leukemic cells from the bone marrow. So that's what makes this one, the acute leukemias, difficult, because basically we have to go into that bone marrow and hit a big reset button with the attempt, to remove all the malignant cells, and then wait for the normal cells to recover and repopulate. And during that time is when the risks associated with infections and bleeding and all the other complications can occur. So one of the unique ones about the AMLs is the M3, and this is acute promyelocytic leukemia. Once again, if you want to test your nurse or your medical student or even your doctor, you can ask them about this one. And what happens in acute promyelocytic leukemia is you get one of those DNA changes as well. And what happens is that we can actually take advantage of that DNA change. And because of the DNA change, the cells progress along and they get stuck again. But really, what happens though is by using a vitamin, vitamin A, you can help the cell move beyond the stuck point. So that vitamin is called all-trans-retinoic acid, or ATRA, which is vitamin A. And in doing that, because you can get the cell beyond that point that's stuck, the outcomes for people with AML M3 are a lot better. Another therapy that we can use, so this came from research by the Chinese, instead of using systemic chemotherapy in a sort of a wipe it out kind of model, it turns out using the arsenic trioxide accomplishes the same thing. So there's difference. There's basically another form of therapy that's a little kinder and gentler and provides similar outcome. So we're going to transition. Let's say quickly, we're going to transition into acute lymphoblastic leukemias. And I put this slide up because it's beautiful to hematologists. Not so beautiful if you have it, I guess. But you can see that these big round purplish cells where the nucleus is occupying most of the cell, and there's no cytoplasm. And this is literally how this looks under the microscope. And over this weekend, actually, my partner, Dr. Curlin, sent me a photograph of this similar cell type from somebody's bloodstream, and we knew what it was right away. So acute lymphoblastic leukemia, if you remember, it occurs in adults and children when they're really young. But on the right, you can see the differences in overall survival. Children do far better with this disease than adults do. And the older you are, the less well you do with this disease. The treatments are usually now chemotherapy-based. We do use antibodies, and sometimes, and in children, we send them for bone marrow transplants. There's also a treatment modality called CAR T cell, which is being used in kids that failed induction therapy, and I can talk a little bit more about that when we're done. So there's a lot of therapeutic options in ALL, or acute lymphoblastic leukemic patients. So I promised to touch a little bit on what causes leukemia. And the slide to the right shows an atomic bomb going off, and the slide next to that is, kids from Japan that are exposed to radiation. And the thing about this is this was obviously a tragedy for the world, but it also actually ended up being an opportunity to understand leukemia and the effects of radiation. Because a lot of the kids that survived the atomic blast, because of the radiation and the exposure and the damage to the DNA, they eventually went on to develop leukemias. And that's one of the short to medium term results of exposure to ionizing radiation. Other things that can cause leukemias is exposure to chemotherapy agents or medications. Certain medications can do it. Certain viral infections can cause leukemias. We live in the Caribbean, where a virus called HTLV1, which stands for human T-cell lymphocytic virus, is endemic. And every year we see a couple of people with that virally associated leukemia. And then some people are just born with genetic defects that predispose them to leukemias as well. So the basic model for leukemias is there's usually some damage to the DNA or to the DNA's ability to fix defects in the replication, either it be ionizing radiation, chemical exposure, you're born with replication errors, or UV sunlight. And on the bottom part of it is that this is usually the body's attempt to sort of repair that, either DNA repair through these various mechanisms, or the body would tell the cell, well, why don't you go ahead and die, which is called apoptosis, and not replicate. But sometimes that gets blocked. You have transcriptional program activation and also cell cycle checkpoint activation. Now, understanding these causes, just like with CML, actually is what drives or underpins how we think about therapeutics for people with the different types of leukemias. So how do we treat leukemias? Because I think I've painted a balanced picture. Some of it's not great, some of it's kind of okay, and some of it's pretty good, you know. So in leukemia treatments, we got a couple of options. We use chemotherapy, which is intended to kill fast-growing cells. And so that works a lot better in people with acute leukemias. You could use radiation therapy to kill cancer cells in the organs, liver, spleen. But typically what we use radiation for these days is more in preparation for bone marrow transplant. So that's the sort of resetting the bone marrow, essentially. Stem cell transplants, and I talked about this with CML, but we use this in other types of leukemias. Basically, either we give you somebody else's stem cells to repopulate the bone marrow, and sometimes we use graft versus leukemic effect. Immunotherapy, once again, this is basically using antibody-directed therapy to treat the leukemic cells based on their cell surface markers. And then we have targeted therapy, which the imatinib or Gleevec is the poster child for that, which basically seeks out and only really works on the cells that have the mutation that are malignant. I put down blood support because typically when people have leukemia, one or more of the cell line is usually decreased, and patients usually need some support when that's happening because their bone marrow is not able to keep up. So I put this last slide in for what leukemia looks like now from a hematologist perspective. Our options are changing. There's medications, venetoclax, which is not really chemotherapy, but basically stops the cell from undergoing apoptosis, takes the blocks out of the cells going under apoptosis. There's, to the right, you see this antibody, this ADC, which stands for antibody drug conjugates, and that looks for cell surface markers. There is CAR T cell, NK cell therapy, which basically tells the immune system to kind of go look for these cells that are abnormal. There's medications that we use to target DNA and how DNA is methylated. And there's also therapies which change the tumor microenvironment. And at this point, I'd like to say thank you for your attention. I know that was a lot. I'll be happy to answer any questions you may have on this.
Rochelle, you were saying something? You have to unmute your mic. I don't know what you were saying. We can hear you.
Sorry, I was saying thank you to Dr. Turnquest. And I was asking if anyone in the audience has any questions to please unmute your mic and you can ask them directly. Or if you have audio problems, you can put it in the chat and we will read them for you. Sorry about that. Lost in space. No questions from anyone? If that's the case, Dr. Turnquest, you must have done a very good job of explaining.
Well, thank you. Leukemia is a really tough subject because most people have very bad experience with them, especially with acute leukemias. It's one that's just sort of been demonized, sort of overwhelmed, but it's changing.
So Christine Chin is saying, mention to the audience some of the tests one would need to work up a patient. And somebody else is asking, are there a lot of cases in the country?
All right. So are there a lot of cases in the country? The short answer is there are a lot more leukemics than most people would realize, especially in the chronic leukemia area. So there are a lot of older patients who have CLL, the chronic lymphocytic leukemias. And we do have a fair amount of people with the chronic myelogenous leukemias. As far as the acute leukemias go in the adult population, it sort of comes in spurts. But this year, we've diagnosed at least 5 or 6 people with acute leukemias. So it's there as far as I go. To the second question, the workup. So the workup just depends a little bit on which subtype of leukemia you're looking at. But the key thing is basically if somebody has an increased white blood cell count that's persistent, just ordering a peripheral smear and looking at the peripheral smear. That is usually a very easy key, especially in the elderly people. Having a persistent white count that's unexplained usually should trigger sort of a peripheral smear look and work up at that point.
Do we do bone marrow transplants here in the Bahamas?
Short answer is no. We do not do bone marrow stem cell transplants in the Bahamas, no.
Okay. So typically patients are referred to the US. Is that the more popular place to do that?
So more recently, no. There are other places around the world that do bone marrow transplants. And so more recently, we're sort of sending people to South America, India, places like that, even Turkey. The thing about bone marrow transplants, and it depends on what you're doing it for. The bone marrow transplants can start anywhere in there for $250,000 on up. And, it's usually sort of not attainable realistically. The bone marrow transplants, though, are becoming less and less frequently needed as we get better with the molecular characterization of the leukemias.
Okay. Are there many misdiagnoses before actually finding the truth? Yes, true diagnosis.
I wouldn't say they're sort of misdiagnoses. what typically happens is that people have a increased white blood cell count or absent white blood cell count. The increased white blood cell count, it goes relatively unnoticed for a while, and the white blood cell count is only maybe 5 or 10% above the normal range, and then that usually results in sort of a prolonged time to diagnosis. But in like the chronic lymphocytics and the CMLs, that usually doesn't result in much of a negative thing. Remember, before we started doing all these sort of routine blood tests on people, these people would go years and years with this diagnosis, and it was only until their immune system was completely shot before the infections and all those other things would crop up. So it's not as much a big deal anymore as it was in the past.
Okay. I see Melissa has her hand up, so go ahead, Melissa.
Good night, everyone.
Good night.
So my question, Dr. Turnquest, is how can lifestyle factors like nutrition, exercise, even stress management, like how do they play a role in supporting patients with leukemia during or after treatment?
And also somebody has a question, once diagnosed, is there a dietary change? So I guess those two kind of are linked.
Okay. For the dietary changes, it's really not a whole lot of a dietary change that we go through. For people with the leukemias, once again, it just depends on whether or not you're dealing with acute leukemia or chronic leukemia. With the chronic leukemias, obviously a healthy lifestyle, people do better and live longer with a healthy lifestyle. There is some look at the impact of vitamin deficiencies. Believe it or not, a lot of the patients that we see in the Bahamas are vitamin D deficient, just don't get a lot of sunlight. And that's turning out to be kind of a big deal, not just for the leukemias, but across the board. And, healthy lifestyles, always people do better with healthy lifestyles. What I wanted to point out, Melissa, though, is that with the acute leukemias, especially like ALL, we see that way more in kids. So, and when I say kids, I mean infants up to 5 years old, so young kids. And so where, those sort of interventions, take on a different space, because they're still growing, that kind of stuff. For people with the acute myelogenous leukemia, one of the things that we're looking at, they often need what's called induction therapy to kind of reset the bone marrow. And when you reset that bone marrow, that's usually at an inpatient along those lines. And that can take a while. So they're immunosuppressed significantly. I hope that answered it, maybe.
Yeah, that was good. That's a lot. I'm just shocked at the fact that we live in the Bahamas. It is so very, the sun is just like,
Yes.
How is it possible that we can be deficient in vitamin D? Like, what is the recommended amount of time that we need to be standing outside to get some sun?
You can be out there longer.
Yeah, so most of the patients that we diagnose with the leukemias and also with solid tumors, as this group may or may not know, there's a rise of colon cancer among the young people under the age of 40 in the Bahamas. And most of those individuals, when we check their vitamin D levels, they're actually low. But it's a lifestyle thing, right? So people go to work, they drive in their cars, they go into the office, they spend 8 hours in the office, they come out for lunch, they go to their cars. Not a lot of time is spent sort of in sunlight, especially if their diet's not great. Vitamin D levels are typically low. So colon, breasts, across the board.
Okay, thank you so much. That answers it.
Anyone else for questions, comments? Please feel free to open your mic and ask, or let me check and see if anyone else has their hand up. Erin, can you help me with that? Nobody else?
No, I don't see any, but I put a thumbs up when Dr. Turnquest talked about deficient in vitamin D. When I did my annual early part of this year, they said I was deficient. And like he said, you come out your house, you go in your car, you go in the office, you stay there all day. I leave work in the evening, so I don't really get the sun as much as I possibly can. Um, but I guess spending what, about an hour or two just in the sun, walking, doing gardening, exercising, would that suffice to bring up your vitamin D level?
So no. It also depends on what you're wearing. So if
No.
you're covered and most of your skin is covered, then we're not seeing people's vitamin D levels go up much. I mean, my recommendation, usually to patients who want to do it naturally, is spend at least 20 minutes out in the sun, between 10 and 12, in shorts and a tank top, or something small. So the exposure
Or go to the beach, eh?
I'll go to the beach. So exposure
Yeah.
to direct sunlight on the skin, is what you're looking for. But a bigger surface area of the skin, not just sort of your arms and sort of piece of your legs. That doesn't work.
Okay. Understood.
I have a question. And this might be a dumb question, but it's okay. What are your thoughts, Dr. Turnquest, on the amount of like the fragrances and these body oils and like just all of a sudden everywhere there is, the sprays and the lotions and the soaps, and I have a teenage daughter. Like, what are your thoughts on the chemicals that we are applying to our skin as it relates to, I guess, any type of cancer? I mean, I know we're talking to about leukemia, and you talked about, well, let's just leave it at that. Like any type of cancer.
So like I was saying earlier, we're seeing worldwide, we're seeing an increased amount of colorectal cancer in our young patients. Um, we're we're also seeing some bumps, earlier bumps in breast cancer among younger women as well. I mean, I can't really talk too much to the fragrances and the like, but part of the theory on the breast cancer part is sort of the increased exposures to estrogens early in life, and what that is looking like as well. So I would say in this sort of fragrances and the like, it may have something to do with the components of that, in those things. And when you put stuff on your skin, just know that you're going to absorb some of it. There's no ifs, ands, and buts about that. There's an absorption.
Okay, thank you.
Mm-hmm. Okay, well, if no one else has questions, Dr. Shea has said, thank you, Dr. Turnquest, for the great talk, and also thank you for the work you do with our cancer patients. And I would like to reiterate that comment as well. Yes, thank you so much. I guess we're seeing a lot more cancer in this country, and so we're very grateful to doctors like you who are doing what you do with those patients on a daily basis. So thank you so much, and thank you for taking the time to join us tonight and sharing that information with us. So I don't know.
Thank you for having
Erin,
me.
no other. Yeah, thank you. Erin, any other announcements or anything else you need to share before we?
No, our next meeting will be, the second Tuesday in October. We had
Oh,
a
yes, we'll
later
be back to our
meeting.
regular schedule.
Yes, we'll be back to our regular schedule as of the second Tuesday in October.
So that date would be actually the 9th. Is that a holiday? Is the 9th a
No,
holiday?
no, the holiday
Oh, the
would,
10th is
that
the
Monday,
holiday. Oh, the
following
Monday,
the
okay.
9th. Yeah,
Oh, okay.
yeah, yeah.
All right, so we hope to see all of you again to our next meeting on the 9th.
And hopefully it'll be a symposium
Thank you all.
more so. Yeah, sorry, it'll be more like a
Yeah.
symposium, so an interaction. Persons can tell their story about their journey with being from being diagnosed to survivorship.
Awesome. So I guess we'll have a lot of our support group folks there, so that'll be nice. So we hope to see all of you, and if each one tells one, we double our numbers, and we make that a very interactive and good session, just like this one tonight. So thank you all for joining. Stay well and keep safe. So thank you all,
Good night.
and good night.
Good night.